Okay, so good afternoon to everybody. First, I would like to thank to Nacho and M. Dolores for organizing this webinar and for allowing me to make this lecture possible with Dr. Moulier and Dr. Berges. These are the 4 points that we are going to see during this next half hour. First of all, I'm going to explain to you what the heart rate variability is, some anatomical and physiological concepts, and how the spectral analysis allows us to infer the state of the autonomic nervous system. Then I'm going to review some studies about heart rate variability as a measure of health and functional reserve in our patient. Then we are going to see the association between surgical stress, inflammation, and nociceptive pathway. And lastly, I will conclude with some clinical cases with the ANI monitor in the operation room. So the heart rate variability is the fluctuation in time that exceeds physiologically in all mammals between 2 beats in a normal sinus rhythm. We can also explain it like the variation in milliseconds between R and R in the electrocardiogram. This variation is modulated by many factors, such as blood pressure, bioreflex factors, but especially is modulated by breathing. That's why it's also called respiratory sinus arrhythmia. When there is any variation in lung volume with inspiration, in order to have a more effective gas exchange, more blood has to reach the lungs. So the parasympathetic system is inhibited and the sympathetic system is activated, increasing then the heart rate. And on inspiration, the vagal system is activated, decreasing heart rate and increasing then the heart rate variability. This mechanism is mediated by the relationship between the pneumotaxic nuclei on the reticular formation in the brainstem and with the nucleus ambiguus and with the dorsal nucleus of the vagus. Both nuclei form the vagus nerve that regulates the heart rate in the sinus node. So, as I said before, during inspiration, the heart rate variability decreases, and in expiration, the heart rate variability increases. Now, this is the screen of the ANI monitor. The ANI monitor records the electrocardiogram of the patient through 2 electrodes placed on the chest or in the back of the patient, and it measures this variability between N and R. And we can see here the sinusoid representing the heart rate variability. And we can see how the distance between beats gets shorter or longer according to inspiration and expiration, and it's formed a wave called rhythmogram or tachogram. Then with this wave rhythmogram, is performed a spectral analysis through a fast wavelet transform, that it is a mathematical algorithm for this kind of irregular, sorry, I don't know what happened here, okay. So I'm saying that a spectral analysis with this rhythmogram is performed through a fast wavelet transform that is a mathematical algorithm for this kind of irregular wave. And it's, for example, like passing the light through a prism, and it discomposed it in its basic component. We have to know that in every spectral analysis, we may have time domain measurements or frequency domain measurements. If we focus in the first moment on frequency domain measurements, we have 3 fundamental components. There is the high frequency component, which is modulated by the parasympathetic breathing. We have also the low frequency component that is modulated by sympathetic nervous system and bioreflex factors. And we have also the very low frequency component that's modulated by hormonal factors and thermoregulation. On the other hand, in the time domain measurements, we can measure the mean or the standard deviation between two bits. The SDNN can be measured by the ANI monitor, which is known there as energy. And we may explain it as the summation of the three components explained before, the high frequency, the low frequency, and the very low frequency component. It's the summation. It's like the total of the autonomic nervous system tone. The SDN, the energy, may also be named in the literature as total power. Here we have again the screen of the ANI monitor, and it shows there three numbers. One of them here in the bottom of the screen, it has been already explained. We have the energy is the standard deviation between R and R in milliseconds. And at the top of the screen, we have in yellow the instant ANI value in the last minute. And we have also in orange the mean ANI in the last 3 minutes. As I said before, the ANI is the normalized high frequency component. And this normalized high frequency component, in some way, it could be explained as the percent of the parasympathetic system of this total of this autonomic nervous system tone. For example, we have here 64 of ANI value. So it means that the 64% of the total of this of the autonomic nervous system is modulated, is the parasympathetic, and the other 36% is sympathetic nervous system. Now we're going to see how the heart rate variability is used nowadays as a tool to measure physiological reserve and fragility. The heart rate variability is a physiological phenomenon that is known since a long time ago. And as is shown here, it has been widely studied, especially in exercise, sleep, stress, or biofeedback. And for example, last year in 2020, there were more than 3,000 of papers regarding to this concept. The heart rate variability is used nowadays by professional athletes to monitor the recovery capacity and adaptation to training, especially in endurance sport. In addition, nowadays, most of our smartwatches, for example, the Apple Watch or Garmin and the smartphones, can measure this phenomenon and give us information about the flexibility to training and the acute stress. In fact, these applications are already used by some clinicians in perioperative medicine. In a clinical way, heart rate variability has been studied mainly in trauma and septic patients. For instance, in trauma patient, it's used in triage to measure the severity and the operations room opportunities. And also in septic patients, these studies has shown that those patients with septic shock with low heart rate variability and imbalance between the sympathetic and parasympathetic component presented higher severity and higher risk of multi-organ failure. We have to take into account that normally in an awake healthy patient, we have energy values between 0.8 and 1.3 milliseconds. When we perform general anesthesia in a healthy patient, the energy values fluctuate between 0.3 to 0.5. And if we have a fragile or critical patient under general anesthesia, the energy values can get down below 0.3. In fact, in this regard, in our latest paper recently published in PLOS ONE journal about ANI and COVID-19 patients, we found that a limit value below a limit value above 80 of mean ANI, or a limit value below 0.41 milliseconds of energy predicted mortalities with high sensitivity and specificity. So at this point, we can conclude that those patients with higher autonomic nervous system tone and a balance between sympathetic and parasympathetic component present better recoverability, better flexibility to stress, and better prognosis. Now we are going to see the relationship between heart rate variability, the nociceptive pathway, and inflammatory reflex for the control of surgical stress. When we face any nociceptive or infectious stimulus, there is always a first pro-inflammatory response, which is mainly modulated in a first time by the sympathetic nervous system. This response produces a strong hyperimmune reaction with a large adrenergic release and a large inflammatory cascade, which increases inflammatory cytokines such as interleukin-6 or tumor necrosis factor. And on the contrary, this pro-inflammatory response is in turn balanced by a compensatory anti-inflammatory response called SARS, with the release of anti-inflammatory cytokines such as interleukin-10, which is modulated by the parasympathetic system. If this systemic inflammatory response syndrome is not controlled to the homeostasis, it can lead a great organ dysfunction and an early multi-organ failure. And furthermore, if this anti-inflammatory response syndrome is not managed and is prolonged over the time, without returning to the allostasis, to the homeostasis, it may lead also a state of immunodeficiency or immunoanergy, which may produce nosocomial infections, such as surgical site infection, fatal outcomes, and late multi-organ failure. So as you can see, the key in our patient is the control of the autonomic nervous system, not only the nociception, but also the control of the inflammation response and the immune system. But how can we do that? Well, we can modulate the autonomic nervous system through the autonomic nociceptive circuit. It is what happens every day in our operations room. When any injury or nociceptive stimulus occurs, for example, the scalpel of the surgeon, that information is sent by afferent pathway through the spinal cord by the spinothalamic and spinoreticular tracts. And before reaching the thalamus, there is a nucleus in the brainstem that directs all the nociceptive and inflammation response, modulating both the parasympathetic and the sympathetic response systems. It is the nucleus of the tractus solitarius that also activates the locus coeruleus and the fight or flight response. This nucleus, through the nucleus ambiguus and the vagus nerve, increases the heart rate, and also it stimulates the sympathetic chain, increasing adrenaline and noradrenaline, and therefore the blood pressure. That's what we are used to see every day in our operations room and how we have regulated analgesia until now. In addition, this nucleus also activates the humoral anti-inflammatory response of the vagus nerve and activates the hypothalamic pituitary adrenal system by releasing adrenocorticotropic hormone and increasing glucocorticoids. Lastly, we are going to see some clinical cases and some practical issues of the use of this monitor in the operation room. In this regard, a new clinical pathway has recently been published in Spain about enhanced recovery in adult surgery, named RICA guidelines. As I show you here, It suggested that the use of nociception monitor may decrease intraoperative opioid consumption compared to standard monitoring with blood pressure and heart rate. On this point, this study was published by Sandra Funke some years ago in Anesthesiology Journal, which shows that ANI is more effective. Here we can see how ANI is more effective than heart rate, blood pressure, and other monitoring in detecting a nociceptive stimulus under different doses of opioids. Furthermore, here you can appreciate this clinical trial published a couple of years ago by Upton in Anesthesia and Analgesia Journal. It has been explained before by Dr. Berges. This study shows that when we titrate opioids intraoperatively according to the ANI monitor, and it's kept between 50 and 70, there are fewer complications and fewer postoperative pain score. So the point here is that we have to try to maintain the ANI values in an adequate balance during the intraoperative, and both overdosing or underdosing of drugs can lead to an imbalance of the autonomic nervous system, which over a long period of time can lead to postoperative outcomes. So it's clear that we have to control the autonomic nervous system, and the fact here is that depending on where we act along this nociceptive pathway, depending on the anesthesia performed and depending on the drugs used, we may have more or less blockade of this autonomic nervous system and more or less blockade of this sympathetic response. This is a case of a radical cystectomy by laparoscopy. Here we can see in the monitor, after the induction and before starting the surgery, the patient presented a basal situation with good energy below 0.3. He was a 60 years old patient with good previous physical condition. And he also has a high values of ANI. The type of anesthesia I performed was a multimodal general anesthesia with low doses of opioids. And in this case, the autonomic nervous system control between I don't know if you see the slide.
Yes, we see the slide, Christian.
No, okay. I was saying that in this case, during the surgery, the control between sympathetic and parasympathetic between 50 and 70, as well as the control of the energy, was optimal during the whole surgery. Here we have another case of an open hemicolectomy with combined general anesthesia and epidural analgesia with low doses of levobupivacaine. As you know, when we cut the nociceptive stimuli at the spinal level, the sympathetic blockade is much greater than with balanced general anesthesia. So here, the ANI numbers tend to be higher, but I try to control the ANI value, the parasympathetic, not above 70 or 80. Here we have also a case of a hysterectomy under spinal anesthesia and sedation. And we can see here also high values of ANI, because in the combination of a spinal anesthesia and sedation, the sympathetic block is practically total. The same occurs when regional anesthesia is used. For instance, in this case, it was performed a supraclavicular block for a fracture of the arm, and he was sedated with dexmedetomidine, which is a potent sympatholytic drug. So the ANI values, the high frequency component, increased to 100% because there was no sympathetic response. Lastly, I'm going to show you two cases of surgeries in critically ill patient. This is a case I had a few weeks ago. It was an emergency in an oncological patient with an intestinal obstruction with sepsis and hemodynamic instability. In this case, we can see a particular thing, which is that the patient had unusual low energy values. This means that the patient's functional reserve and the total of the autonomic nervous system here were beginning to collapse. In this oncological patient, I performed a multimodal general anesthesia, maintaining a careful balance between the sympathetic and parasympathetic between 50 to 60, and trying to not debilitate even more the autonomic nervous system. This is similar what happened in this last case of a critically ill COVID-19 patient. We have to undergo here to this patient an emergency surgery for an open cholecystectomy. As you can see, before any stimulation, the patient had an ANI of 86 or even an instant ANI of 99. That's why he had almost a total depletion of the sympathetic system, and the energy was also at the limit of 0.09 milliseconds. In this case, I perform a balanced general anesthesia with low doses of analgesia, and we can see here, after the stimulation of the surgery, the ANI numbers decreased slightly, but the energy values did not increase. So in a total depletion and an awful prognosis, in fact, this patient died a few days after. So we have to be aware of the functional condition of the patient, and we should maintain a good balance between sympathetic and parasympathetic, especially in more fragile patients. To sum up, the take-home messages will be that the heart rate spectral analysis allows us to infer the state of the autonomic nervous system and the nociceptive inflammatory and immune system. Although heart rate variability and autonomic dysregulation in preoperative patients could be associated with a worse prognosis, this autonomic dysregulation represents the cause of the surgery stress and its inflammatory response syndrome. And our target should be the control of the autonomic nervous system, promoting the balance between the sympathetic and parasympathetic component, mainly in the frail or critically ill patients with low functional reserve. Thank you very much.